Hi, guys.
Hello.
Hello. Hi. Hold on one second. I'm not hearing everybody. Oh, here we go. All right. So first things first, welcome to OB Pals. I need you guys to sign into a QR code. I'm going to give maybe 1 more minute just to see if anyone else is going to show up. So let me go ahead and share the code with you guys. Okay. Do you guys see it?
Yes.
Okay, great. So go ahead and scan it. And you can let me know when you've done it. Are we all good? You can type it in the group chat if you'd like. You don't need to say anything. Awesome. Thank you, Sophie. Okay, so the QR code is just for you guys to sign in, just kind of like proof that you were there. They ask that you guys do it. It's not my policy. Sorry.
So do I'm sorry, where do I do that?
Okay.
In the mobile attendant, the West Coast app or?
Oh. So you need West Coast can sometimes make it a little more difficult, but you kind of need to download a QR code scanner, if I'm right. If any of you guys know differently, let me know. But from what I know, you kind of have to download the QR scanner and scan the code and sign in.
If you have an iPhone, you can just pull up your photos like you're going to take a picture or something. And if you just hold the camera over it, it will also pick it up, by the way.
Thank you, Dustin.
No problem.
Thank you, that worked. Thank you.
Awesome. Well, now I learned something new too. Okay, did everyone finish? Other than Tanya, I guess, is doing it now.
I'm done.
Done? Wonderful. Okay. If everyone's got done, I'm going to stop sharing the QR code. Okay. Okay. Got it, Young. I'll let you finish up. What professors do you guys have? Hartman, Sharper. Okay. Right, because Professor Sharma is in the hospital, so she isn't actually teaching this term from what I know, but I'm pretty sure all of the tests and everything that you'll be lectured on, it's her material. Is she? Oh, that's great. Okay, that's awesome. Hopefully she'll be back week 4. Young, did you finish? Can I stop sharing? I hope I said your name right. I don't want to be. wrong. Yes? Okay, great. Okay, here we go. All right, great. So I had Professor Sarkeesian last term for OB. I really loved her. But I do know that some things are different with the way they teach. I had a study group with 3 friends, and one was also in Sarkeesian with me, and the other 2 were in Sharma/Dr. Hartman. And I know that there are a couple of differences in what they're teaching and how they may be testing, because they like to emphasize certain things. So I know for Sarkeesian, she really loves talking about and testing on fetal heart rates. But again, it also depends on what's going on this term. So maybe they'll change their minds. I was told to let you guys know, that this recording will be on YouTube. I have the links in an email that they sent me. So if you guys want to refer back to it when you're studying, you can. If you don't want to, if this doesn't help at all, you don't need to. I do also need to ask you guys to let me know what you're having trouble with and what you'd like to go over. Because unfortunately, I can't reteach necessarily, but I can explain and try to help you guys. So if anyone has an idea of what you'd like to start with, please go ahead and let me know. FHR, okay. What specifically about FHR? Are we talking about reading one or understanding why we do one? Reading one, okay. Okay, that's fine. Okay, so the great thing about FHR that I have learned is that what makes it dangerous. All right, have you guys gone over this wonderful acronym called VEAL-CHOP? I'll type it. VEAL-CHOP. Yes, okay, Tanya has, Dustin hasn't, Mary somewhat. All right, so VEAL-CHOP is, yeah, literally what saved me. Sarkeesian went over it, and when I had sim, we went over it. Have any of you guys, or any of you having sim soon, or next week, Saturday? It's not hell on earth, I promise. You'll probably have a good time, actually. Lies. No, I swear. Here's what I should ask. Okay. Sorry, I'm pulling up some things that can help with FHR so that before we do it, we're ready to go. Okay, so the other thing I want to ask is, who of you like OB and want to go into OB or are thinking of going into OB after? Because it will make a difference of how well you learn it. I've found that to be true. No one? Just me then, that's fine. Not you. That's okay. Thank you. Okay, so I found that if you really love the subject, which is true for anything, you learn it a lot better. So I picked it up really quickly because it is what I want to do. But I have a friend who absolutely does not, and we worked on it together and she got it really quickly. So that's hopefully what we'll do here. I'm going to go ahead and share a whiteboard. You might have to bear with me. I am very technologically handicapped. Sorry about that. Okay. So here's what we're gonna do. We're gonna write down what VEAL-CHOP is. So V stands for variable. E stands for early. A stands for accelerations. I'm going to write accels, just so you know it's accelerations, okay? L stands for late. On the other side of the pond, they correspond with one another, okay? C is chord compression. Oh boy. Oh, here we go. C is chord compression. H is head compression. O is okay / oxygenated. Oopsies, that's next. And P is placental insufficiency. That's right. Okay? So this is what field shop is. This is really, really helpful when you're reading. If you're able to recognize what you're reading, then it'll be very helpful to figure out what's going on with the baby, with the fetus, it will be the fetus because you're doing NSTs and that happens 28 weeks, sorry. All right, so here's what happens. They do correspond with one another. So a variable decel is equal to chord compression. Chord compression does not necessarily mean you have the cord fallen through the cervix and now it's an issue. That's like not necessarily what it means. It could mean that the baby has turned over and is laying on it, and during contractions it's pressing more with the head. That could just be possibly what it means, that the cord is being compressed while the contractions are happening. But it could also mean that we have a cord prolapse and that it's an emergency. We have early. Early is equal to head compressions. When we see early decels during labor, we're not that concerned, okay? We're kind of expecting some head compression because, you know, the baby is going through the canal or, you know, making its way through the cervix. The head is going to be compressed when there are contractions. So early ones, we kind of expect to happen. Would we like them not to? Sure, but do they happen often? Yeah. Accels are accelerations. Accelerations are great. We love accelerations. Accelerations means that the baby is fine. The baby is doing amazing. The baby's oxygenated. Their nervous system is intact. They're happy. They're fine. We love accelerations. We love accelerations when we're doing an NST. Have you guys covered NST yet? Yes. Okay. Awesome. Wonderful. So we all know that an NST is a non-stress test. It begins, correct me if I'm wrong, we start doing it around 28 weeks. Do let me know. I'm having Pete stuff through my head. So, okay, great, awesome. 28 weeks. Okay, and what we're looking for when we do an NST to make it a reactive NST, we want accelerations, and we want moderate variability, and we want, oh my, a nice normal baseline between 110 and 160. Okay, now there are the specifics. You want a 15 by 15 for an Excel. You're doing this in 20 minutes or 40. If you're having concerns and you want to do it longer, you can do it for 40. But with an NST, we're looking for accelerations to verify that the baby's oxygenated and that their nervous system is intact. That's in an NST. In labor, when we're looking at the FHR, we don't necessarily need accelerations to tell us that the baby's okay. In fact, we're not really expecting them because now the baby's going through kind of a stressful process of being born. And so when we see accelerations, we're excited and it's great, but we're not necessarily expecting them. We're more expecting to see what we like to call moderate variability. Moderate variability means that if you look at the little boxes, which we'll look at in a moment, each little box, have you guys seen an FHR tracing before? Yes, no, Maybe once, but you have no idea what you saw. Yes, okay. Okay. So if you ever seen an FHR tracing, you see that there are little red boxes, right? Right. So one little red box is 10 by 10, okay? 10 seconds by 10 seconds. Now, when we're looking for moderate variability, and if you've ever been to a hospital or if you've ever seen a baby born, you'll see that on the side they're looking at the heart rate, and you'll see 136, 140, 148, 130, we're looking for moderate variability, which means that there's going to be a difference between the baseline and 6 to 25 numbers. So if our baseline for baby is 140, which is a beautiful baseline, we love 140, we're looking to see that the baseline does fluctuate, that we're seeing some fluctuations, we're seeing lovely squiggles, and we want it to be between 6 and 25. So if I had a baseline of 140, if the baby is showing that it goes up to 146 or 150 and it comes back down to 140 and it goes down to 130, 135 and it comes back up to 140, then we're good. We're seeing some nice moderate variability. All right. Are we kind of getting moderate variability? Sorry, I took a quick break from VL Chop to go over that. Yeah, sure. Okay, so that's variability, which we'll go over again in a moment. I just wanted to tell you about the difference between accelerations and our expectations for NST and labor, because there is. In labor, our indicator of a nice, happy baby is moderate variability. In an NST, it's accelerations. Okay. Late D cells are bad T cells. Just like variable D cells we don't really love, late D cells we really, really don't love. Late D cells mean that we're looking at placental insufficiency. Not good. Really, really not good. We don't want placental insufficiency because while the baby is still in your womb, it is still reliant on your placenta. Okay? So late D cells means that something is wrong. We have to go in, we have to see kind of what's going on, figure out our best method. If we're seeing late D cells and the baby's almost being born, like we're basically, it's time, we're not going to be super, super, super concerned. But if we're seeing late D cells and it's late in phase, she's only 2 centimeters, we're going to get a little concerned. Now, for each deceleration, we do have nursing interventions. Yeah, we do have nursing interventions. So with cord compression, what we like to do is try repositioning. Because if it is the baby laying on the mother, then laying on the cord inside of the uterus, then repositioning may mean that we've moved the baby off of the cord. And then we shouldn't be seeing variable D cells anymore. With early ones, there aren't really interventions we can do. Their head is going to be compressed and it's going to show up. But again, with early D cells, we're not as concerned. Accelerations, we're not doing anything. And with late decelerations, we are definitely going to do an intervention. We want to make sure that the baby is okay. And we want to make sure that the mom is okay. So hold on, let me pull up what I need to be able to help you guys. Hold on. I don't ever want to give you wrong information. Okay, here we go. So with placental insufficiency, the intervention for late D cells, we're going to reposition mom. We're going to put her in the left lateral position. It gives the maximum blood flow to the baby. Okay. After we reposition mom, we're going to give her oxygen and we're going to give her an IV fluid bolus again, to increase the amount of blood flow to the baby. And if we're seeing late decels with more than half of the contractions, we're gonna wanna deliver. Okay, great. There's another deceleration. There's another deceleration that we don't necessarily go over in veal chop because we hope that we don't see it. And it's not one that I believe we see incredibly often, but there is a deceleration, and I don't think you really need to know it right now, but just to be familiar with it. There's a deceleration called a prolonged deceleration. It can be cord compression without relief, so when we see a cord prolapse. It could be placental abruption, maternal hypotension, which is related to an epidural, hypertonic contractions, which I don't think you guys have gone over yet, but hypertonic contractions are contractions that last a very long time. So we usually want our contractions to last up to a minute with at least a minute of rest in between. And with hypertonic contractions, we're usually seeing them lasting longer than a minute and with less time in between. Maternal seizures, narcotic overdose and respiratory depression, and rapid fetal descent and a uterine rupture can cause prolonged decelerations. That's a lot of things, but they are nicely listed for us so that we are aware of the possible causes. For prolonged deceleration, we basically do the same thing that we do for a late. We reposition. If she's still having prolonged decel, then you give her IV fluids, you give her oxygen, and then you consider, everything's a consideration, because remember, you're dealing with 2 patients and mom may be opposed. Consider expediting delivery if the deceleration does not resolve. And if mother fights you on that, you can explain to her why you'd like to speed things up and how this will help her and help the baby. Are we following so far, or am I just confusing you guys? Please let me know if I'm confusing you guys.
I'm good. I have a quick question though.
Yeah.
When basically you do have late or you're expediting delivery, there's a medication that you give, but it's on the tip of my tongue.
A lot of medications.
Which is the normal, not normal, but I guess the more widely used?
Okay. So when we're talking about expediting delivery, so let's say that she's already in labor, she's in active phase, she's 8 centimeters, she's 90% effaced. Great. I don't think you've learned about that yet, but when you do, you'll understand it a little more. Let's assume that she's there and now you're seeing these late decels and they're happening really, really often and you're getting concerned. You want to get this baby out. At that point, the most widely used, and I'll tell you what it is Pitocin, which is basically, exactly, good job, Stephanie, synthetic oxytocin. We'd give her Pitocin to help her contractions. However, and here's why I say however, if she's 8 centimeters, her contractions are moving, it's going and she's making it, but the Pitocin is having a bad reaction. Like let's say her Pitocin is causing hypertonic contractions, we're seeing an increased length in the contractions and the contraction duration, and the frequency is quite often. Like we're seeing it every 30 seconds and they're lasting 95 seconds, then we're probably going to stop the Pitocin because now we're going to give the baby even more issues. We're probably going to start seeing prolonged decels, and that's not what we want. So if we've tried everything in our power, we've given her the Pitocin, we're seeing a bad reaction, or we've gotten her to walk around if she doesn't have an epidural and we're not seeing any difference, then we're going to start talking about probably a C-section, because if this baby is really, really unhappy, we're going to want to get the baby out however we can, right? Okay, wonderful. Okay, so this is veal chop. Awesome. We're all kind of getting veal chop. We're all kind of getting the interventions. Yes, no, maybe. Cool. Here's what I'm gonna do for y'all. I'm gonna put the causes and the interventions up here. Hold on. I don't know if you can see that. Oh no. Hold on. I just don't want it to disappear all the way on the bottom because that's a problem. All right, I'm gonna move it. If you guys can see it, you see for early, it says the cause, and then the intervention is nothing, keep monitoring, right? Yes. All right, I'm gonna get rid of it so that we can see the ones on the bottom that are continuing, okay? Early's easy, early we like, early's normal. Then we have late, which we saw as placental insufficiency. Here are the interventions for late. You want to reposition, you want to give her oxygen, IV fluid, and if you're seeing them with more than half the contractions, you want to deliver, okay? Okay, you guys are definitely going to be going over this more. I don't know about Hartman for sure, but I know with Sarkeesian, she definitely does. And I'm aware that Sharma doesn't necessarily focus a lot on FHR. That's what I've been told. So I'm going to assume that's still happening even with Hartman. Okay, good to know. I'm a wealth of information. All right, here we go. Variable, cord compression, change mom's position. If it's related to a prolapsed cord, then it's a different story. Then we're running, if you've heard the story of the prolapsed cord, have any of your professors told you how much they want to do this? Not yet. Sarkeesian and my clinical professor would tell us how excited they were, how they've always wanted to have a prolapsed cord happen while they were on shift so that they can hop onto the gurney, stick their fingers up the mom's vagina to press baby's head off of the cord and ride their way all the way to the OR, where they would consequently climb underneath the table with their fingers still inside of the mother's vagina until the physician has cut open the baby and they meet their fingers together. Then she can let go and the physician pulls out the baby. That's the story. It sounds really fun. I'm not saying I wouldn't want to do it. I get why they want to do it, but you know. Yeah, that is a lot. Hold on, I accidentally got rid of this. IV fluid 2. That sounds nasty. I love it. Just a little bit, just a little bit. Yeah, one of my professors did. She said she got to do it once, and it was the most exciting moment of her life. Yeah, poor mom. But at that point, I feel like, you know, hopefully she got an epidural. Because you're not waiting, you're not doing a spinal, you don't have time. I hope she had an epidural. Okay, all right, awesome. So this is prolonged, but again, I don't think you really need to know that right now. So this is veal chop. We're good with veal chop, amazing. The next thing we're gonna go over are how to read them. Love it. Well, I didn't find. I was really lucky to have Sarkeesian. Sarkeesian is freaking fantastical. And she gave us this really great website. I don't know if she's given it to you guys yet, but if I were you, I would I would utilize it. 100% definitely use it because it's super, super helpful. I need to remember what it's called, so give me 1 second. And that's kind of, we'll do practices on that after we, where did I put it? I'll find it. I have an older computer. She doesn't like when I have too many things open. 1 second. Oh, I found it. All right, the EFM tracing game. Has she given it to any of you guys yet? If you're in her class. Yeah, oh great, Mary has it. Awesome, thank you, Mary. Yeah, it's like ABG Ninja, but I find it more fun. Okay, so what we'll do is we'll go ahead and practice on that later. But before we do that, I just want you to understand the basics so that you can even recognize it, because if you can't recognize it on a standstill tracing, you're probably not going to be able to recognize it on that. So here's what we're going to do. Well, we can start with recognizing baseline and variability, and then we can maybe, someone else just joined that I didn't see. Maybe I'm crazy. Here we go, back to whiteboard. All right, oh, how nice, they saved this for me. Well, I'm gonna get rid of it. Okay, so, oh boy, they don't put it on like that. Okay, then I guess we'll do it like this. I'm gonna trust you guys. I've been told from pals that we can share stuff with you, but we can't have you guys take pictures of it or copy it. But you know, unfortunately, I could never know if you did it, right? So I'm just gonna share this with you and put my trust that you won't take pictures of it. And we'll use this quick tracing to kind of go over what we need to go over. Which one was it? Is this the one I'm doing? All right, so we'll start with this. She has a couple of good ones. Can you see it? Yeah, okay. So this first tracing, first we should probably go over what the top and bottom are. I'm sure you guys know, but you know, just a quick refresh. So the top part is the baby. This bottom part is showing the contractions. Right now I'm looking at the bottom part. It doesn't look like mom's having any contractions. That's fine. This could possibly be from an NST. That's also fine. So when we look at this, what do we see as the baby's baseline? If it's blurry and you can't see, do let me know. I don't know what I could do, but I won't hold it against you if you can't figure out the baseline. Looking at it, just throw it, what are we saying? 145 heart rate. Yeah, that kind of looks definitely is very close. I would say 130, 145. Yeah, so 130 to 145, great guess. I would say 140. So anything in between 130 and 145 is just about right. Okay. Now, in order for you to even know if you're having decelerations or if you're having accelerations, you do need to figure out your baseline. And it could be between those numbers. It could be something else entirely, and we don't know. But I would say 140. Now, if I said 140 and I'm looking at this right here, if you can see my mouse, do you see my mouse? Yeah. Yeah, okay. Right here would technically be what I think would technically be an acceleration, because if I were to say that she's at 140 and you see the little box, that's 10, it looks to me that it's going up 15 and it's going down 15. So for me, if I said 140, it would be an excel, right? Good job, Mary. If you said 145, that's not an acceleration. If you said 130, that's absolutely an acceleration. I think 130 may be a little bit low, just because this would be where 130 is. And I can see why you'd think that. I can see why you'd think that, but I would say probably 140. Yeah, that's fine. You don't always get it right on the first try, and 130 isn't that far off. So if you said 130 though, it would definitely be an acceleration. Here too, we could technically say that this here is also an acceleration. Okay, so that's how you'd read it. This is also a beautiful FHR tracing. If I had someone walk in and this was their FHR tracing, I'd be like, oh my God, you have such a happy baby. We love this baby. Because I'm also seeing some nice moderate variability here. So this is a great example of baseline, some moderate variability, and a couple of accelerations. Okay. Here she's kind of showing you, God bless her, Keisha. So yeah, so I'd say baseline between 135, 145. Accel is 15 increased, followed by 15. Ooh, okay. So 15 by 15 means 15 by 15 is the box, is like how much we'd like it to be like this. So it's not necessarily 15 decreased back to baseline. It just means that lengthwise on the bottom, we want it to be 15, and up to the top, we want it to be 15. Does that make sense? Or did that just confuse you guys even more? Yes, that makes sense. Okay, great. To all of you, or just kind of? Okay, so, I'll draw for you guys the boxes. I'm not an artist, so I do apologize, and I suck at straight lines. I do apologize. But, okay. Can you guys see the boxes? Right, each box is 10 seconds. So if, here are the boxes, okay? Yeah, we want it to increase by 15. So that means that I would want it to be like this and like this. Can you see it? The little boxes in the bottom. Okay, right. So we want it to be from here to here, at least 15, and from here to here, at least 15. Does that make more sense, Mary? Dustin got it. Awesome. Okay, great. No problem. That's what I'm here for. If I can't explain to you 15 by 15, I'm no good. All right. So that would be that. Now, let's look at variability, because Sarkeesian was wonderful and she taught us about variability. So variability, if you can see here, it says absent is undetectable, which is true. If you look down here at this wonderful FHR that she drew on, absent you can't see. It's basically a straight line. When we see absent variability, we are very, very, very concerned. We don't want absent variability. Minimal can be okay. If we're giving mom Stadol in the latent phase, or fentanyl in the latent phase of labor, which we do not give in active, we will give it in latent to help with her pain, and we see an FHR that's minimal variability, instead of getting concerned, we say, oh, it's a Stadol baby. Stadol can make the baby, you know, have minimal variability. They're basically lethargic. They're sleepy. They got meds. They're not up for anything right now. They're going to be minimal. Sleep can sometimes make it minimal. Things like that will change the variability. So if you know what's causing the minimal variability, it's not necessarily that big of a cause for concern. However, if you didn't give her Stadol, or if you don't think the baby's sleeping, or anything else doesn't make sense, minimal variability, it's concerning. We don't usually like to see it. This is moderate. Moderate is 6 to 25. Love moderate. Moderate is our gold standard. And this is marked. Marked is not something we always love to see. It's a little too extreme. So what we always want to see is moderate. Here, see? Oh, this is wonderful. I even wrote it down for you guys. What are some factors associated with decreased variability? Narcotics like Stadol, fetal sleep cycle, hypoxia, and mag sulfate. Why do we give magnesium sulfate? There are 2 reasons. Does anyone know? I don't know if they went over this. You don't need to know if they didn't go over this. So if we have a mom come in with preeclampsia or eclampsia, which we don't want, but if she comes in with preeclampsia, we're going to give her some max sulfate. We're going to first give her medications to lower her blood pressure, and then we're probably going to follow it up with max sulfate so that we decrease her chance of getting seizures. Exactly. Oh, Stephanie, great. See, I'm like not always paying attention to the comment section, but Stephanie got it, to prevent seizures. Now, if mom comes in and she's in premature labor, we can sometimes give her max sulfate to slow it down. Cool? Cool. All right. Sorry, Do I have another one? Yay. All right. So here's a strip. I don't know if you can see it. I can barely see it. Oh boy. Well, if none of us can see it, I'm not going to use that one. Oh, here's a good one. Okay. I'm not going to ask you about baseline. I can't read the numbers. If I can't read the numbers, you definitely can't read the numbers. I'm not going to expect that of you. But I want you to kind of look at it. I know it's a little bit blurry. And I kind of want you to tell me, what are you seeing? Are you seeing, yeah, you're seeing a lot of variable decelerations. And it's a good thing that you said variable, because when we talk about the characteristics of our decelerations, it's very important that you know this. There are different types of characteristics. Variable can look like a V, can look like a W, can look like a squiggle, can look like a mountain range. It basically can look like, woo, that. Cool? A variable deceleration is exactly what you're seeing. Now, if I'm wrong, I'm very sorry. But from what I've learned, these are variable decels. Variable decels can be confusing because yes, they look very strange and funky, and that's how you'll probably know, but they can also be in a place where you'd see an early decel or a late decel. Does anyone know where you'd see an early decel and a late decel? If no, that's okay. That's not a problem. An early decel, which we said can be normal, is caused by head compression. When are you going to have head compression? When you have a contraction. So early decel will completely match up excuse me, with the contraction humps. So you see these are contraction humps, right? Thank you, Tanya. These are the contraction humps. I have drawn an example here. The little, there's a name for it. I can't remember the name for it. So I'm gonna call them humps. I'm sorry. But this part of the hump is gonna match up completely with the contraction. Do you see it? They're basically mirror images. Now, it doesn't mean that the early decel has to be the same size as the contraction. Absolutely not. But they're mirrored. So you're going to see one right on top of the other. Okay? Right. Thank you. Okay. If it's confusing you, let me know. I'll try to explain it a little bit better. I'll find a way. We're good? Okay. A late deceleration is also a little confusing because you may get it somewhat confused with an early, and that's fine. I'm not a professional. I can also, when I do my FHR tracing game, I also get things a little off. That's okay. We're still students. We're still learning. But with a late deceleration, if you see this one right here, it kind of starts at the peak of the contraction and it ends after the contraction. Do you see the difference between the early and the late? Yeah? Okay. So that's how a late decel, how you can differentiate between an early and a late. Early and late decels also are not going to come in funky shapes like variable. They like to be nice and uniform and kind of rounded. So that's another way you can kind of work it out. Okay. Now, the reason why I say variable can sometimes confuse you is because yes, variable looks funky-dory. You know, it's not, doesn't necessarily look the way that early and decel do with their shape, but they can be a little bit tricky, and they can sit like this. So we see this first decel here, and it looks like it's mirroring your contraction, right? Right. There's a perfect mirror in early decels, not in late. Late starts at the peak of the contraction and ends following. This variable decel looks like it's mirroring, but it's a variable deceleration because of its shape. There we go. You got it, Jan? Okay. Yes. Okay, good. So same with this. It's like a fun trick that they like to play with you. This one could even be, you could say, oh my God, it's totally late. Are you wrong? Yes, but I can see why you'd get confused because it almost looks like it starts at the peak and ends after. Okay, so just be aware of the different characteristics of these decelerations. A decel is also characterized by 15 by 15 on the bottom. So if it's only 10 by 10 and you see a little small bump on the bottom that's 10 by 10, it's not a decel. It's just a heads up. Okay. Oh, here's great. This one's great. So if you can see, again, I'm not going to ask you for baseline, but if I'm looking really closely, I would say that this is not a happy baby. This looks like a baseline of maybe 100. Can't really tell very well. But this is already not a happy baby. And if we're looking at the variability, what would you guys say it would be? You can guess. I won't say anything mean about it if you get it wrong. For variability. So we're not talking about decels, right? Minimal, right? So I know that like a lot of the words sound very similar. It's not on you, Kat. It's not on you. Variability is the moderate, minimal, absent. I know it can be really confusing. And decels are variable, early, late, prolonged. So when I'm talking about variability, just like Tanya said, it would be minimal. So what I see here is a very, very unhappy baby. Got it. Awesome. Good. That's what we want. And I'm seeing some very minimal variability. I'm also seeing, from what I can tell from these very blurry small numbers, that the baseline is lower. So I'm seeing bradycardia. And I'm also seeing a couple of decelerations. Now, from what I'm saying, this would be a deceleration. It looks like it's 15 by 15. I'm sorry, I can't tell. It's a little bit blurry. But I want you to kind of go through and tell me what do you think this one is first, and then we'll go through the rest. So what are we thinking this deceleration is? Late. Awesome. Good job, Tanya. Yeah, it's late because it starts right at the peak of the contraction and it ends after it. Okay? Oh, good job, Tanya. All right, what about this one? What are we thinking this one is? Early. Yep, that's right. Good job, Mary. It's early because it mirrors. Perfect. Awesome. You guys got it. It mirrors our contraction. You see how it mirrors? Like, it doesn't necessarily have to be perfect. It doesn't have to look exactly like the contraction, but we want it to be right above the contraction, just like this. Now, what are these two lovely decelerations? Variable. Good job. Variable decels. Now, you guys don't need to know how to read the contraction part of the tracing yet, do you? No? You can take that as a no. Not yet. Okay, then I won't go over it just yet. We don't need you to get more than you need. I don't think you do. I don't think you do, because if I'm right, when we're talking about hypertonic contractions, that's later on. That's like week 7 or something. So I don't think you necessarily need to. If you do, I do apologize, but I don't think you need to right now. So here's what's great is that we've done some practice. We're now able to kind of recognize them a lot more. That's great. What we're gonna do now is we're gonna go, oops, stop sharing. We're gonna go over to our fetal heart rate game. Now, it does ask about contractions and it does ask about categories. And I don't know if you've gone over categories, but you don't need to get flustered about it. You don't need to think you have to answer it. If you want to guess on the category, you can guess on the category. If you want to guess on the contractions, you can guess on the contractions. But also remember that if I get it wrong, I'm not a professional, okay? Okay, great. That's all I'm putting out there right now. So that when you go to your professor and you say, my OB tutor, she put the wrong category. Please don't. I'm trying to, guys, I swear. All right, here we go. Let's share the EFM tracing game. So much fun. Do we all see the tracing game? Yay. Yes, okay, great. So we're gonna start with collection A. So here's what we do. Ooh, we press start. What are we in a profession? We're a registered nurse. In this situation, that's what we are. We go ahead and we start. All right. I'm gonna let it run through and then we're gonna pause it and we'll talk about what we're seeing, okay? Okay, great. And stop. Okay, here we go. First of all, let's look at this baseline. What are we thinking about this baseline? Where do we think it is? If we're drawing a line kind of in the middle of what we're seeing, what do we think it is? Normal, right? Yeah, oh, good job, Mary. I would agree. I would say it's about 140. So we'll put normal. Good job, guys. You got the first part. It's baseline, it's normal, it's beautiful. Now, if we're looking at variability, what would we say it was? Moderate? I say so too. I think it would be moderate as well. Good job. We got it, moderate. Tanya, I wanna ask why you think it was marked. I'm not calling you out. Oh my gosh, no, I hate when professors do that. I'm just asking why you think it's marked, because it looked marked. Okay. Because you're seeing it kind of big, right, in the spacing. I can see where you kind of get that. But marked is more drastic. It looks like this. It kind of looks like that. Okay, okay. Right, so this is nice and moderate. We like this. You're welcome. Now we said that our baseline is probably, could be at 135, 140. Do we see any accelerations? Yeah, I would say yes as well, but let's all remember this is a game, so what they think their own baseline is might be different from what we think our baseline is. So if we do put accelerations present and they say no, it's not on us, it's because their baseline might have been different than what we thought it was. Okay, I'm gonna put yes, I'm gonna put present. It's there, woo! Good job, Mary. Mary got it. All right, now let's take a look. Take a quick gander. Do we see any decelerations? Remember, you need to differentiate variability and decelerations. See, thank you. You guys kind of fell into the little trap. Okay, remember, what did I say about decelerations? How do we know for sure that they're going to be a decel? What is it? Kind of like an accel. How do we know? It will be 15 by 15. 15. Right, Kat. So starts at the peak would be a late decel. But what I'm looking for is that 15 by 15. So we'll know that it's actually going to be a deceleration and not just a variability thing when we're looking at the 15 by 15 rule. So if you guys were looking at this one over here, or even at this little guy over here and thinking, oh, it's a decel, I'm not going to fault you for thinking that because, okay, no, because if I hadn't known any better, I would say the same. But we have to remember that a decel would be 15 by 15, meaning it would go down 15, but it would also go to the side 15. And this is not exactly there just yet, okay? 15 by 15 below baseline is a decel. I do want to say yes. Oh God, now I'm scared I'm giving you all the wrong information. But I'm gonna say that this is absent. Yeah, okay. I'm going to say that this is absent because it seems very much so absent. Usually with decels, Marian, here's what I'm going to tell you so that I don't give you the wrong information. It should be 15 by 15 below from what I'm remembering. But they're also pretty recognizable. So this little guy here, thank you. This little guy here wouldn't be a decel. And if you saw, I can always show this to you guys. If you saw these top ones again, you'd see why, because they're usually pretty recognizable. And that little dude doesn't really look like a deceleration, okay? Now, I don't think you guys have learned categories yet, and that's okay. I'm not expecting you to know. But if I'm having a beautiful normal baseline, and I'm seeing moderate variability, and there are accelerations, and there are no decels, what category do we think it would be? 1, that's right. A nice normal category. Good job. It would be normal. Now, normal is normal baseline, moderate variability. If there are accels present, then accels present, and no deceleration. That's a normal category 1. Category 3 is when we have absent or minimal variability, as well as something else, like continuous late decels or continuous variable decels, or we're having bradycardia. It's that absent or minimal variability with something else. Now, don't 100% quote me on that, because it could be something else and I'm not 100% right, but that is what I learned. You guys will go over this later, so it's not something you need to know right now. I'm just giving you like a quick little overview. That's kind of what I've learned. So that would be an abnormal, and intermediate is anything in between. So if you had a normal baseline and you had moderate variability, and you don't have accels, but you have late decels, it would be intermediate. Indeterminate. Oh my God, I can't read. But this is beautiful. This is nice and normal. We like this. Now, contractions, you guys haven't learned that yet. But here's what I like to say. If you look at the boxes, you can see that the small boxes are within big boxes. Do you see it? Here's a line and here's the line. Yeah. So between here and here is a minute. Okay. Fun tidbit so that you know that's a minute. So if we looked at this, I would say that the duration is 1 minute, and we're having them every maybe 4.5 minutes. But we want, remember, we said we want at least a minute in between. And I would say that this is probably a nice normal frequency for contractions. Good job. See? Nice and easy. So that was our first one. They were really kind. They gave us an easy one to start with. I do appreciate it. Yeah, this is a really, really great website to practice with. Is it 4 contractions for every 2 minutes? Is it normal? Yes, 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 yes. If we're having 5 or more, then we start getting concerned. Then we're starting to say, okay, this looks hypertonic, or this looks like tachysystole. But when it's 4 in 10 minutes, it's normal. That's okay, right? Because if you did the math, remember, we want 1 to 1. That's great. We love 1 to 1. Then we have time in between. So if our contraction was 1 minute and we had 1 minute in between, we have room for 5 contractions in 10 minutes. That's why we say 5 or more, we can start getting concerned, because we'd rather it be a little more time for baby to breathe in between, right? Because when you're contracting, what happens is you're basically doing this to the baby. That's why when we see head compression, it's okay. You're doing this to the baby. That means that everything is now constricted. Our placenta is kind of constricted, our cord is kind of constricted, our baby is kind of constricted, and it's a lot harder for them to get in the oxygen and the blood they need. So if we have a contractions that are lasting, I almost want to say more than 90 seconds, but we'll say more than 60 for right now. Then we can start seeing that that this length of contraction is having an effect on the baby. Because they do need time, just like us. If you were to dunk my head underwater for a minute and then you pulled me back up and gave me another 2 minutes to breathe and then stuck me back down, I'd be okay because I'd have those 2 minutes to breathe. But if you were to stick me down for 90 seconds and you were to lift me up and not even give me 30 seconds to breathe and stick me back down, you're going to start seeing that I'm having trouble, right? It's kind of like that. Yeah, that's how, oh, cool. Good job, Hartman. Ideally less than 5 contractions. Ideally less than 5. And we want to say, yeah, about 1 minute rest period is just fine. But we want to see less than 5. That's a good marker. No problem. All right, let's play another one. We'll see if they give us any D cells. Okay. Next. All right, here we go. I'll pause it in 1 second. All right. Where are we thinking that the baseline is at? $150? I would say that the baseline is like 140. Yeah, good. That's right. 140, 150. So I'd say around 140. That's okay, Mary. That's okay. I get where you're going because you went with the bottom section. That's fine. We usually like to draw it kind of straight in the middle where we think it is, where the middle is. You can always be sure the variability is nice and lovely for us today. But that's kind of what we like to do. We don't really go with like the top part or the bottom part. We like to go kind of in the center. Yeah. All right. All right, so what would the baseline be if it was around 140, 150? Normal, that's right. Normal, awesome. You guys got it. Because our normal baseline is 110 to 160. I'm so sorry, I'm just congested today. Variability, where would we say our variability is? Moderate, yeah, good job. I would say moderate too, let's hope it's right. It's right. Good job, Dustin. All right, now I'm expecting a very unanimous answer, but are we seeing any accelerations? Yes. Yes, these are great. These are wonderful. This would also be what I'm assuming is an NST because I'm not really seeing any contractions. So this is beautiful. If I was doing a very active baby, right? If I was doing an NST on this mom, I'd be very happy. Are we seeing any D cells? No. I also think no. Good. And this would be what category? 1. Yeah. For the contractions, I think it'd be more data needed to define. Awesome. All right. So see, they gave us, they're so nice. They're giving us happy babies. Yeah. So this is, again, this is a nice normal category 1, and you guys got it. Maybe this next one, they'll give us some D cells and we can experience what it looks like. I'm so proud you guys are getting this so well. I'm either really good or you're really good. All right, here we go. You're sweet. I think I'm okay. Oh, well, I'm glad I can help. I'm really happy I can help. All right. Oh boy. This is an interesting looking tracing. What are we saying our baseline is? Let's give a quick gander guess. 165, tacky, yeah. I would agree, I'd say this is tacky because this looks like it's definitely 165. Yeah. 160, you could also say it was 160, but from what I'm seeing, again, I'm kind of drawing that line at the midpoint right here. I'd say it's around 165, but it's definitely tacky. What are we saying about our variability? Minimal? I also think it's minimal. Marked? Are you talking because of this part, Young? Yes. All right, so this is like a small instance. This could be even that the taco moved. We call it a taco, sorry. Not the taco. The heart rate monitor moved, our Doppler moved, and it could just be because of that. Or it could just be a quick moment of marked variability, but we're looking at the overall, and I would say that it's probably minimal. Please be right. Yeah, it's probably minimal. So we see it. Good job to you guys. But Young, you get why this is probably not marked because of this one section? Just gotta make sure you get it before I go on. Yes, okay, great. Are we seeing any accelerations? Do we see any accels? Absent, that's right. Absent. What about decels? Late? Yeah, I'm also only seeing one. So what we can do is we can continue forward, see if it happens again. Because that one's almost tricky. I would also say that it was late. However, the placement of it was very, very interesting to me. So what we're gonna do is go over here. Okay. 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 So I'm seeing this too. Apparently it's happening. However, I can't be positive if this is a late or if this is a variable. It's not at the peak though. Right, it's not the peak, and it doesn't seem to necessarily start at the peak. Exactly, it's very hard. So what we can do is go with what you guys said, and we can go with late and we can see what it says, okay? Yeah, 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 yeah. It's either late or it's variable. So let's see if it's late, shall we? It's late, good job, guys. All right, now that they say it, I can explain it. Technically, remember I said it was based on shape. So it wouldn't really have been variable because it isn't a very funky shape. Yes, good job, you guys got it, I'm so proud. It's very nice and rounded like this. And technically, if you look at the contraction, it's starting here, which is still within where the contraction is kind of falling. Now, does it mean that it has to start at the peak? It kind of starts at the peak because we can start seeing it go down, right? We start seeing it go down and it ends after the contraction is ended. So yes, the right, it would be late. Good job. All right. Oh boy. What category are we saying? 2? Any other guesses? I think 2 or 3. Okay, give me 1 second. Because remember, I want to make absolutely certain that I'm not giving you anything that's wrong. Okay? Okay. So it depends on your professor, what they say for 3 or for 2. 3 could either be, and this is why I said 1 second, so that I can make doubly sure. 3 is, I like to say minimal or absent, but I would say in this situation that it's absent with something else. So in this case, I want to say that it's probably a 2. Okay. Okay. Oh my God. Yeah, good job. So here's why I'm going back on what I said. I went to make sure, again, that I'm not giving you wrong information, and I went to look it up. Now, I like to look it up because if the internet is saying something, a lot of the time they're right, and our professors and our books, ATI and our textbook and the internet, they all sometimes say something different. And when it comes to the categories, I'm going to say that 3 for you guys is absent with something else, either bradycardic or continuous late decels. That would be 3. Sorry, I may be just confusing you, but I'm going back on what I said. For 2, it's anything between normal and 3. So this would be 2. Makes sense. Okay. Tanya, you get it? Did I confuse you more, or is this okay? Kat, do you get it? Got it? Okay, awesome. Now I'm looking at the contractions, and I would say that this is either normal or more data. They may say more data. I'm going to say normal. Normal. More data. Why do you think it's more data, Young? See, I was also thinking of the same. It could be one or the other. But I kind of want to hear what you were thinking. Why? No reason. You guys haven't gone over contractions. It looks like it. So you wouldn't really know just yet. That's okay. When I look at it, I am seeing they're not weird looking contractions. You know, they're showing me that here's the contraction. It looks like it's maybe 30 seconds. And we have maybe 2 minutes. And here's some contractions. And here's a nice contraction. And now we have about a minute in between. And here's, you know, it's giving me the data that I need to make this deduction. You guys know that's why it would be normal frequencies, because it's a nice normal length of contraction, and the frequency is nice and normal. It's about a minute to 2 minutes in between, and that's okay. Sometimes 3 if we're looking at this one. Should be normal. But you guys do know that when we put on an external monitor, which we call the tachometer, we call it a tacho, to measure the contractions, we are not measuring how intense they are, okay? So this, it could be right. They could be saying, oh, this may be how actually intense they are, but the external tacho can't actually tell you that. If we were doing internal monitoring to measure the strength of the contractions, which we do sometimes do, it will tell us, and then we can match up what we're seeing from that reading to this reading. Okay? But when we're doing external, these fun peaks here don't actually tell us how intense they are. Not always. Cool. Yeah. So that's what that situation is. It's really great for measuring frequency and duration, and that's what we use it for. So we're looking at this baby. I would say this is probably an unhappy baby. Remember, what did we say late decels are caused by? What are late decels caused by? Placental insufficiency, right, good job. And when we see a tachycardic baby, if baby came in already tachycardic, okay. When we see a tachycardic baby, we have to check mom. The #1 cause for a tachycardic baby is a mother with an infection. So if I were to look at this, I'd say, you know, maybe she's having chorioamnionitis, you know, the infection of her amniotic sac. Maybe she's sick. Maybe just she has the flu. We don't know, but she could have an infection, and it could be causing the baby to have tachycardia. Because when we're sick, we're also technically can become tachycardic. So that's what I'd say. If I were to look at this, I'd say, oh, mom may be tachycardic. There's some placental insufficiency. Maybe she's 39 weeks, so it wouldn't be the calcification of the placenta. But we don't know. Yeah, the most common one for a tachycardic baby, the most common cause would be maternal infection. Cool? Fun, you learned something new. Intervention CBC. Sure, why not? Well, you know what? Here's the thing with the CBC, and here's the thing with taking a temperature. I don't know if they went over this, but if they did, great, it's a review. If they didn't, awesome, I'm teaching you something new. Moms, pregnant women, their temperature and their white blood cell count sits at an elevated number. That's normal. So what you'd see, you might have a pregnant mom come in with 13, with her WBC count at 13,000, and it's normal because they're elevated because she's pregnant. That's what can happen. Her temperature may also be elevated. She could come in with 99.8. She could come in with 100, and you can't be 100% sure if she has an infection, if she has a virus. You can't be sure based on just WBC and temp. You have to use other methods to figure it out.
I have a quick question on that.
Yeah.
Could you use like a previous white blood cell count to like use as a different baseline and then see if it's altered from that?
Oh, that's a really good question. So Sarkeesian, I don't think I ever asked her that, or I don't think anyone ever asked her that. It would make some sense the way you think about it, because it's very med surg to think that way. That, oh, well, if her baseline at the beginning of pregnancy or even at 28 weeks was 13,000 and she came in and now it's 14,000, could she be sick? Maybe, but it could just be that it went up a little bit. We can't be 100% positive using that WBC count, okay? What I would say is if you are suspecting, that is the right word, yeah. If you are suspecting infection, they'll probably ask for a culture, or, you know, they'll test the amniotic sac, or if she really looks sick and she's saying, oh, I don't feel well, other than the fact that she's in labor and about to have a baby, then we can start thinking about infection. Okay.
That makes sense. More like they would be looking for the root of it, not necessarily just value. Okay.
Mm-hmm. Yeah. And I say ask your professor. She'll probably tell you what she thinks. And the great thing about Sarkeesian is that she's also a midwife. I believe it's a midwife, not just an NP. She may also be a midwife. So she has a lot of experience. She'll probably know for sure. Whereas I can only tell you from a student standpoint what I learned and what I think. And from what I learned and what I think, I believe you need to get extra information before making that decision. Okay, cool, awesome. Anything else about infection? Oh, there's something you all need to know. When we give an epidural, or even when they get closer to that transition stage of labor, you're gonna see moms start getting shivery, and they'll be like violent shivers. It's not an infection. It's not a sign of infection. It happens. It just happens. There are a lot of things that are flooding through her body. There's so many hormones that are going on in there. Plus, if she had an epidural, or Jesus Christ, if she had an epidural, or if she's having Pitocin or anything, there are extra stuff. Her body's just dealing with it, and it's going to shiver very violently, and that's okay. That's normal. We're not worried. Okay. Just as something to expect. Are you guys going to clinical this term or no? No, okay, yeah. We didn't either. Some people are. Oh, Young, you're so lucky. Oh, I'm jealous. I really wanted to go. I didn't get to go. That's okay. You know, sometimes they let you and sometimes they don't. It's up to the hospital. And if you get it, you get it. Oh, you're going to Valley Press. I'm going to Valley Press for children's, for peds. Children's, peds. Wow, my English is really doing well today. All right. Sorry, we kind of got off topic. That's great, Young. I hope you have a really good time. You're probably gonna have a good time. Let's look at this tracing. And tell me what you think the baseline is. Any guesses? 130, yes. Yes, good job, Mary. You finally got what you wanted. Yeah, I would say it looks to be 130, and that's normal, right? That's normal. Yeah, okay. Let's look at the variability. What are we thinking? What are we thinking our variability is? Moderate. I also want to say moderate. To me, it looks moderate. It could be minimal, but I would say moderate. Right. So here's what, remember how minimal looked like last time from our last tracing we just did? It looks little bitty baby. It looks like a little small thing. This one I would say is moderate because if you see, it does kind of extend to 10. Everyone kind of extends up. Sure, there are some smaller spots, but they have an extension, they have a range of at least 10, and of at least 10 we can work with. If it's less than 6, then we're looking at minimal, okay? This would be more moderate. Right, so Mary, that's exactly how I would think of it too. Minimal is more little lines than linear. Yeah, that's how I think of it. Your professor might say something else. And you know, if she says something else, please listen to her. I'm not the one testing you, she is, to go with what she says. But I would say that it's more little lines than linear, okay? Are we seeing any accelerations? Absent, no, that's right. No acceleration. Very good. What about decels? Seeing any decels? Early? I agree with Tanya. I think I'm seeing an early deceleration. Could we be wrong? Could it be something else? Sure. Sure. I'm not perfect. I don't know everything. But I would say that this looks like an early decel because we're looking at the peaks of each and they're kind of lining up. So I'm going to say early. Let's hope it's right. It's right. Woo. Good job, Tanya. Yeah, that makes sense since it's mirrored. As long as you get it, then that's what's important. If you didn't understand why it was early, then we could have a conversation about it. But if you get it, and that's awesome. Now let's look at the category. What would we say our category would be? One. You guys are saying 1. Should we put normal and see what it says? Two? Okay, so I think it may be 2, but if you guys want, we can put 1 and we can see what it says. Do you want to do that? Do you want to put normal? It's up to y'all. Yeah, you want to put normal? Okay. It's normal. All right, it's a little Brady. No, Brady, it's not a little bradycardic. I was thinking in terms of early decels I wanted to put indeterminate. That's why I wanted to do it. However, early decels are normal, so I can see why it would say. Sarkeesian kind of taught us that, from what I remember, that with an early decel, we wouldn't necessarily say it was a normal 1 category, but she may have said that it was and I missed it because, you know, we're not always paying attention to online. I'm scared now. No, Stephanie, why are you scared now? It's not a little bradycardic. Remember, what we're looking for in terms of our baseline is between 110 and 160. So 130 is right there. Okay? But yeah, it's definitely normal. On the quiz, are we going to be tested like this? Do you mean, are they giving you something that's going to keep going? I can say that I don't know about Sharma. I really don't know about Sharma, but for like a picture of this, yeah, for Sarkeesian, she really loves FHR and she'd always stress to us during class, know your FHR, know your FHR, know your FHR, because she said to us, she actually said it, so I can say it to you because she'll let you guys know that she tests on it. She'll give you a strip and she'll ask something about it. Okay, she may say, normal baseline, early decel, bradycardic baseline, absent decel, you know, something like that. Probably something like that. But she'll give you a picture and she'll probably ask you with her multiple choice, what's going on. Okay. She's really wonderful. So if you have Sarkeesian, Mary, did you say you have Sarkeesian? Was it you said? Me. Oh, Kat, you're so lucky. I just love her because I had her, but I mean, I don't know. And Young has, okay. Sharma Hartman, okay. Sarkeesian, I don't know if Sharma or Hartman do this, but Sarkeesian gave us a couple of case studies, and one of them, from what I showed you before, was this fetal heart monitoring worksheet. It's not required, you don't have to do it, but I would actually suggest doing the worksheets and doing the case studies because they were very helpful. And she likes to make sure that you understand your FHR. To her, it's super, super important. For Sharma, I know it's not as big as something that she presses, but I would still know it just in case, because maybe you'll have it on the ATI proctored, or maybe it will be on the final, or you know, you never know. So you still want to be aware. Cool? Cool. You're welcome. Sorry, normal frequency contractions. Guys, we're doing really, really great with this. Tell me if you guys want to move on to another subject though. And we can stop and we can move on to something else. It's up to you. It's your tutoring session. Okay. Let's talk about this baby. What's going on here? Where's our baseline? Let's start easy. Where's our baseline? 145, 150? Yeah, I'd say so too. So that's normal, right? Normal. Okay, good. We have a normal baseline. What's going on with our variability? Minimal. Very good. It's very, very minimal. And here's how you know that it's for sure not absent, is we do see some little bumps. It's not all the way straight cross line. It's not a flat line. It's minimal. Awesome. Are we seeing any accelerations? No. No access. Mary, are you thinking yes because of this spot right here? Yep, okay. So let's say that we decided our baseline's 150, which I would say it's a lot closer to 150. So let's say it's 150. If you go up here, you're going to see that it actually only goes up 10. It goes down to the side maybe about 18, but it only goes up about 10 or 11. So we can't have that. Remember, it's 15 by 15 is what constitutes an accel. Those are our minimum numbers, right? So you can't have 11 by 18. It's not really an accel then, okay? Okay, are we seeing any decelerations? Yes, we're seeing decels. How sure are you, Young, that it's early? Remember, what are the characteristics? Variable, Tanya says variable, okay. What are the characteristics of early that differentiate it from variable? Because remember, I said they're gonna trick you, it's gonna be tricky, it's gonna look something like this, and we're gonna say it's early. But we can say that it's variable, right, based on peaks, based on the shape, the V shape, exactly. So this would be, I would say it's a variable. Now, maybe it's early, maybe I'm wrong, but I would say it's a variable, okay? And that's because of the V, exactly, V for variable. Oh, that's a good way to remember it. You'd think I'd say that, but I couldn't. Yeah, so that would be variable. It's tricky, Young. I so understand where you're coming from. When I first did this game in like week 1 or week 2 or whatever it was, and I still didn't have a huge grasp on FHR tracing, I also was like, oh, it's early, because I was like, peaks, they match, but it's not. Because remember, early is nice and rounded, variable is funky. It's V for variable or very funky. Cool? Cool. All right. What is our category going to be? What are we thinking for our NICHD category? Two? All right, I think it's also 2. It's 2. Woo. Good job, guys. All right, our contractions are looking a little funky. I want to continue in a second. From what I'm seeing, we're looking at tachysystole. Now, this could be more data needed to define. However, I'm going to go with tachysystole, and it is right. Can you explain the category again? Yeah, no problem. No problem. There's a lot of information thrown your way. It's okay to forget. All right, so categories. Normal category 1. Category 1 is normal baseline. Accels can be present. They don't have to be present. If it's an NST, please have it present. But when we're talking about labor, it doesn't have to be. Variability has to be moderate. You can't have minimal, you can't have marked, you can't have absent. It has to be moderate. So normal baseline, moderate variability. Accels are either present or not. And I suppose, according to this, according to what I remember from Sarkeesian, it's not. But according to this, an early decel can also be normal, which it is in labor, it's normal. So I can get where it's coming from. That's normal category 1. Category 3 is absent variability accompanied with something else. So if we're saying absent variability and late decels, or absent variability and we have a bradycardic baby, and absent variability, we're having prolonged and bradycardic, I mean, forget about it. We have to get the baby out now. But that would be a category 3. Okay, so 2 things have to be abnormal and 1 of them has to be absent. All right, now if your professor says something different, if she says to you, hey, listen, for me, I want category 3 to be minimal and absent variability with something else, then it's minimal and absent variability with something else. But according to this, it's only absent, okay?
I'm sorry, could you repeat 1 and 2 one more time as well for the categories?
Yeah. Okay, so 1 is normal baseline, moderate variability. Accels can be present or not, because remember, in labor, they don't necessarily have to be. And decels are either absent or there's early, because according to this game, early decels you can add within category 1. I would ask your professor, make sure they're fine with that, because they might say, no, we want a normal category 1 without decels. But according to this, early decels within category 1, because they are technically normal. Okay, so that's category 1. Category 3 is our absent variability with another problem, like a late decel or a bradycardic baby. Again, ask your professors. They may want it to be minimal variability with something else as well. It depends on who you're asking. It's how it is in nursing school. Category 2 is everything in between. That's what the professors will tell you for sure. Category 2 is everything in between. So let's say you have a baby who has bradycardia, moderate variability, there are no accels, and there's a late decel. That's category 2, because it's not with normal, but it's also not 100% abnormal. It's not absent variability with something else. Kind of making sense? You see, okay, because I know category 2 can be a little confusing. Yeah. Somewhat for 2, that's okay. Yeah, I know, I'm sorry. I believe you go over the categories. I just want to be certain. I don't ever want to give you anything wrong. A little later. If you get things wrong in the game, does it explain why? No. No, I believe that it does not. Yeah, I know. It's not fair. They shouldn't do it like that, but they are assuming that you're already a nurse. What I would say, if you get something wrong and you're not sure about it, check your notes and check Google, okay? They usually will be able to explain it to you. Why are there NAs? So sometimes you can't always tell. You can't always tell what you're looking at, okay? And you won't necessarily know what to put. So NA, no answer, is NA, no answer. So if you saw something where it looked like, okay, here's absent, here's minimal, here's moderate, there's marked, I would put NA. I would have no idea what I was looking at. Or if you just don't know and you don't want to guess, put NA. Okay, it's a game. You're not getting graded on it. Your professors can't see it. It's for you to learn and understand FHR tracing. Okay, I think that's it. I think 5 is it. Yeah, we did it. Good job. If we're ready, can I ask about, yes, absolutely. Let's get out of here and we'll talk about amnio infusion, when and why. Okay, give me a second. Whoa. All right, so we're talking about amnio infusion in terms of doing it when you're already in labor, right? Kind of. You guys are learning about amnio infusion right now? Okay, actually, hold on. I really am very interested to know. Are you learning about amnio infusion right now, or are you learning about amnio infusion? Oh, right, you're in quiz 3. Haha, I'm kind of stupid. Amnio infusion. Hold on, okay, sorry. Amnio infusion, where you're putting amniotic fluid back into the sac. It's in the study guide for week 2. Jesus Christ, guys, how did this happen? All right, I don't remember learning about amnio infusion in week 2, but that's okay. If they want to start you early on that, they can start you early on that. Amnio infusion. So amnio infusion, guys, can only be done when your water has been broken. Okay, and here is why. We infuse, usually with normal saline or lactated ringers, we infuse this room temp transcervically, because we have to get into the uterus. We have to get into the sac to be able to do this. So we have to do it transcervically. That means the water has got to be broken at this point, because we're putting in an IUPC, intrauterine pressure catheter, to transfer in the fluid, I won't call it water, the fluid into your amniotic sac. So your water has to be broken. Now, we'll usually do it if you have oligohydramnios, or if you're seeing some variable decels and you're like, what is going on? It could just be that the fluid has depleted and the baby is now closer to the cord, so now they're able to compress on it a little more. So that could also be what's going on. Or let's say she broke her water. She was only like 3 centimeters dilated and 60% effaced. When that happens, when she's still in latent phase and her water breaks, we are super, super concerned about cord prolapse, because there's nothing really there now. There's a little bit, not all of her water's gone, but there's not a lot there to help keep the cord within. It's not floating. Now it's kind of just like, oh, gravity's pulling me down, let me go. That's kind of what's going on. So it's with oligohydramnios related to broken water, we're concerned about cord prolapse. So we'll usually have her now on bed rest. And if we're seeing variable decels, we're thinking, okay, well, her cord is in prolapse. Let's say you checked. Her cord is in prolapse. Baby's probably laying on it because now there's more room for them to be right next to each other. Let's maybe give her an amnio infusion. So that's when we do it. Variable decel, if a variable decel is indicating it, or if there's oligohydramnios, we do it. And you have to do it when her water is broken. Now, this is a Band-Aid fix. We do it maybe once. We're not going to do it 500 times. That's a lot. It's also a waste because her bag's already broken. It's going to continue leaking out. It's going to. It's not going to just stop all of a sudden. You don't have one gush of water and then you're done. You're leaking through the entire thing. That's why we put the puppy pad on the bed so that she doesn't get herself all wet. So it will continue leaking. We usually do it once. It's a Band-Aid fix. Now, this is not for meconium dilution. All right, so you've heard of meconium staining, right? Yeah, okay. Yeah, okay, so meconium staining means baby is pooped in your uterus and they're stressed. They're either really, really stressed or, you know, they're past due. And when you're past due, that means baby technically was supposed to be out of the womb a week ago. Let's say they were ready to go poo. They're going to go ahead and do it in your uterus. So they're either really stressed or they're post-dates, and that's okay. We do not give an amnio infusion to dilute the meconium staining. Okay, it doesn't make sense, like, right? Okay. Logically, you wouldn't. What is it going to do? It's already been in there with the baby. Now it just has to get flushed out. So you wouldn't give it to dilute the meconium. All right. Nursing interventions. So you want to monitor the infusion. You have to monitor the infusion. Remember, anything that goes in has to come out. So if I'm giving her, I'm not giving you normal amounts. Like, I don't actually remember normal amounts. But if I was giving her a liter of normal saline and her amnio infusion, which could be wrong, don't use those amounts. But if I were, I need to know exactly how much went in her so that I can tell that she lost that liter again. We don't want anything staying in there. That shouldn't really be in there, okay? So we're gonna monitor her infusion. We're going to check the intensity and the frequency of the contractions, because remember, anything you give her might affect her contractions. Check the vital signs. You want to check maternal vital signs, and you want to educate why you're doing it, what you're doing, what's going on. You know, they get worried. These are moms in labor, especially first-time moms. They're gonna look to you for all the information they can get about what's going on. So that's kind of amnio infusion. Amnio infusion is not that complicated, okay? If it's complicated for you, I'm sorry, that was probably really insensitive. But in general, it's not that complicated. Any more questions about amnio infusion? Anything we want to clarify? No? I'm good? Okay. Justin's good. Anyone else good? Are we all good? Good, okay. Any other questions about anything else? Anything? I just want to make sure, oh yeah, that it was, okay. Do we have any questions about, I don't know, what's going on in week 2? God knows I don't remember what was happening in week 2. Oh no, is this the time when you're doing all the antepartal tests? Like the different testing? So Justin, did you mean amnio infusion or did you mean amniocentesis? Infusion, you mentioned infusion, okay. It's really interesting to me that they talked about that, but that's okay. do you guys want any, do you have any more questions about intermittent auscultation or continuous? Again, the NST and positive is okay. Yeah. That's great. We can definitely go over that. Okay. So an NST, let me get up my notes so that I also give you all the information I possibly can. All right, so NSTs are done 28 weeks or more, right? Because at 28 weeks, the baby is now developed, they can move, they can choose when to move, everything is there, they're good, they're ready to go. 28 weeks, they're moving, so that's when we can do an NST, a normal stress test, to see what's going on with baby. Is baby happy? Are they oxygenated? Is their CNS intact? Or is something going on that we don't know about? So that's what we're doing. We usually will do an NST if mom comes in, she's really, really concerned, she's all flustered, she hasn't felt her baby moving. Before we do the NST, we'll say, okay, well, did you do the fetal kid count? So we'll have her do the kid counts. We want to make sure that for sure baby isn't moving. And then we'll do the NST. Now with an NST, we can give orange juice before, just to kind of give her some sugar. Maybe the baby was sleeping. Maybe they just were exhausted from their night in the town. And we're going to give her some sugar just to see if maybe we'll wake her up. So we give her orange juice. We don't always have to, but sometimes we do. And we'll start the NST. The NST is for baby if it isn't moving. We do it at 28 weeks, I'm pretty sure, regardless. If it's a high-risk pregnancy, if mom is preeclamptic, if she has gestational diabetes, if she had pregestational diabetes, you know, we're going to do it. And then if baby is past due. If baby is past due, you're going to be doing these every 3 to 4 days. They're only good for every 3 to 4 days, if I'm right, unless it was 3 to 5. 3 to 4. It's 3 to 4, I'm good. Every 3 to 4 days is how long an NST is actually good for. So when you're past due, you're going to come in every 3 to 4 days to get checked again. You're past due. This is a baby that should not really be in there anymore. So we're always checking. The procedure, so what do? We use an external transducer or a Doppler, or whatever you want to call it, and we put it on the belly. And we may also run a contraction strip for interpretation, because if she's having decelerations and we don't see her contractions, how do we know for sure what they are? So we'll also do the contraction strip just to see what's going on. And sometimes we will also do, we'll be checking mom's heart rate at the same time. So if you remember how our strips looked, where the baby's heart rate is, where we saw the babies, under it, not in the contraction strip. The contraction strip is kind of different. Yeah, under the baby's heart rate, you'll sometimes see mom's, and it's just to kind of match, see what's going on. So that's that. Now, with an NST, there are different ways to interpret. There's actually only 2 different ways to interpret. You have reactive and you have non-reactive. With NST, we don't do positive, we don't do negative. We say reactive or non-reactive. We want a reactive NST. If it's reactive, that means baby's reacting well. That's how I like to think of it. Okay? If it's non-reactive, it's negative. It is not good. So, yeah. So for us to have a reactive NST, we want fetal movement, we want a well-oxygenated fetus and an intact ANS, CNS, and we want to see it with our accelerations. So that's how we'll tell if all that is going on, is with our accelerations. If we're seeing some beautiful accelerations and we're seeing, I want to say, oh, correct me if I'm wrong, 2 to 3 within 20 minutes. Yeah, it's 2 to 3 within 20 minutes. Wow, we're happy. It's a good baby. But let's ask, if you have 2 accelerations within 20 minutes, but the baseline is 170, is this still a reactive NST? Do we know? Do we have any clue? I've run my NST. It's been 20 minutes. I saw 2 X cells. Great. But the baby's baseline is 170. Am I going to document this as reactive? Yes? No. Okay. So Kat's right. The answer is no. It's non-reactive. For it to be reactive, we want it to be a normal baseline. We want it to be moderate variability, and we want to see 2 ACT cells within 20 minutes. And we'd prefer not to see D cells, okay? So no D cells. When we're interpreting NST for it to be reactive, I'll say it one more time. Normal baseline, moderate variability, 2 ACT cells within 20 minutes, and no D cells. Okay? Okay. So if I were to say, I'll give you 3 more questions like this. If you have 2 ACT cells, but minimal variability, is this reactive? No, right. What if I said I have 2 ACT cells, but there are also decelerations, you know, maybe like 1 or 2 here and there. Is this reactive? No, that's right. No, it's not. And what if I had 1 ACT cell during 20 minutes? It's 1 ACT cell, you know, there's still an acceleration within 20 minutes. Is this reactive? No, that's right. Exactly. It's not reactive because we want 2 within 20 minutes. Now, sometimes we're willing to extend it to 40 minutes, and we'll usually do that if we're suspecting maybe baby's sleeping. Because remember, a baby's sleep cycle is about 30 minutes. So it could just be that when you were doing the NST, it happened to be the one time that they decided to go to sleep. That's fine. If we're seeing it be as non-reactive, okay, we're not seeing any ACT cells, it looks a little bit minimal, we don't know what's going on, we're first going to not panic, because we don't want to panic mom. And then we're going to do this lovely thing called vibroacoustic stimulation. What? So excited. It's this little acoustic simulator that you put to the abdomen, and it makes this sharp sound to kind of wake up the fetus. So if you're not seeing any spontaneous ACT cells, within 5 minutes, you're going to apply a single 1 to 2 second sound simulation to the lower abdomen, to where we're thinking baby probably is. And we're gonna see if maybe it wakes them up. If it's not, you can do it again at the end of 10 minutes if there's no spontaneous movement, so that we could see the 2 movements within that 20-minute window. If vibroacoustic stimulation is not working, okay, that means now we're dealing with a non-reactive NST. Our next step is an AFI and then a BPP. BP. Woo! So an AFI is used to check the amniotic fluid. It's called an amniotic fluid index. It's basically an ultrasound. It just measures the amniotic fluid in the 4 quadrants of the uterine cavity. And we're using it just to see, maybe she has oligohydramnios. You know, we don't know. Maybe she's polyhydramnios. Maybe something's going on in there. So our ultrasound is measuring the amniotic fluid, but we are still looking in. We're kind of seeing. So 5 to 25 is a normal amniotic fluid index level. We like that. Anything below 5 is oligohydramnios. This can be caused by hypoxia. The placenta may not be functioning well. The fetus is going to become hypoxic. They may deal with premature birth. We may be dealing with intrauterine growth restriction. That would be with oligohydramnios. With polyhydramnios, it's anything over 25. Causes for polyhydramnios: maternal diabetes, there could be a fetal infection, twin-to-twin transfusion, if you guys have learned about twin-to-twin transfusion. I think you have. I think that was week 1. Fetal abnormalities, placental issues. It could be idiopathic. We may not know what's causing the polyurethromatosis, but it's not something we want to see. So that's what when we do the AFI. If the AFI comes back and it's not normal, what are we going to do? We're going to continue with the rest of the BPP. They all sound like the same letter to me. So hold on. All right. So the BPP has 5 criteria. You have an NST and a 30-minute ultrasound, and you have an AFI, fetal movement, fetal breathing, fetal tone. Cool? So if we've done the NST, we've done the AFI, now we just have to follow it up with that ultrasound to check fetal movement, fetal breathing, and fetal tone. What we like to see with the BPP is a score of 8 to 10. What's okay, but we need to monitor it is 4 to 6. And what we need to immediately intervene in is if we have a level of 1 to 4. Okay? So that's a BPP. I like to say NST, AFI, BPP all in one go, simply because they're all pretty much related. A modified BPP is an NST and an AFI. If the AFI is normal, we don't have to do the rest of the BPP. We just kind of have to figure out what happened to that NST. Maybe something was up. Cool? So that's an NST. Do you have any more questions about an NST? Do you have any more questions about an NST? Thank you. Or are we good with an NST? No, it's good. Okay, good. Do you have any more questions for these last 3 minutes? I am yours for these last 3 minutes. You let me know. You're good? Already, I know time flies when we're having somewhat of fun. You're good? Okay. Do you guys want, oh, dang, I didn't see that email. Sorry, I just saw that. I don't even think they're here. Sorry, weird. Okay. Do you guys want the YouTube thingy? Or are you good? I have to find it. Oh, here, I found it. Do you have any ATI codes? Unfortunately, I don't. I don't think they gave us any ATI codes. If you're looking for ATI codes, I would go to the NCLEX specialist. Maybe they have some, but I don't think I did get any ATI codes. If that's what helps you, definitely go. Also, do those RN case study thingies, just in case. Hold on a second. That's the YouTube link if you guys want to go rewatch it. I don't know when it will be posted or anything, but that's the link. Do those RN cases because they're very helpful. They're very helpful. That's all I would say. Okay? No problem. Anything else before you guys go? I'm here every Friday, 12 to 2. No, don't be scared for Sarkeesian's class. I swear, she's amazing. She gives you a lot of information, but she's great. Oh, thank you. You guys too. Oh, thank you so much, Young. That's very sweet. You're so welcome. You guys are so welcome. Thank you, Stephanie. That's very, very sweet of you guys. All right. So whenever you guys are ready, you guys can go. If you want to email me with any questions or if you need extra help, I'm usually up to do any extra help that you guys may need. So just let me know. Okay? Okay. Bye, guys.